Good morning, everyone. Welcome to today's panel, Responsible Use of AI, Promoting Health Equity and Analysis Across Populations. My name is Kathleen Snyder. I'm a senior counsel at Wilson Sonsini, where I focus my practice on the intersection of technology and healthcare. I also spearhead the firm's digital health initiative. I am pleased today to be joined by this fantastic panel as we will discuss aspects of data and social determinants of health and really promoting that equity across AI. So I think I would like to start off with introductions, and I'm going to go around my circle. So I'm going to start with Sanjeev. Could you introduce yourself? And
Yes, sure. Good morning, everyone. Thank you for making the time to join us on this exciting session. My name is Sanjeev Wadhwa. I'm the president and CEO of an AI-driven startup called Singularity. Until recently, I was a partner at Ernst & Young, leading their America's Life Sciences R&D and Health Innovations area. And I've had the privilege of working across payer provider pharma over the last 35 years and would love to share what we're doing with health equity and hopefully help move this discussion forward today.
Great, thank you, Sanjeev. Judy, can I have you go next, please?
Hello, everyone. My name is Dr. Gichoya. I work at Emory University, where I'm an interventional radiologist and who also works in informatics and specifically on medical imaging. And I am excited to be on this panel and look forward to a really engaging discussion. Thank you.
Excellent, thank you. And John?
Yes, good afternoon, good morning, everyone. My name is John Olwal. I'm the global head of digital ethics at Novartis, and I'm based out of Basel, Switzerland. I'm really looking forward to this discussion on how we can bring experience from the industry, how digital ethics is being more important. Thank you.
Excellent. Well, thank you, guys. So I'd like to kick off our first question, our discussion around how we bring in environmental factors and social determinants of health into the data sets that make up the basis of AI. There is a lot of discussion about the inherent biases in the data that we have, and that it is not robust enough to have a full population approach. And so I was wondering if you guys could start, and maybe, again, I'm going to start with Sanjeev. If you could talk a little bit about how you guys have brought in the social determinants of health.
Yeah. Well, thank you. So I think part of our approach when I came from a precision medicine background and had spent over 2 decades sort of learning what that domain, how we could apply that domain, and we just couldn't find all the answers. And 5 years ago, when we began building our platform, we didn't know whether this was going to be called health equity. After a number of things that have occurred in our community over the last year or so. And so beginning the process, we had to kind of understand what all this meant. And now looking back, we sort of think that we were working on the problems of race, gender, for equality of outcomes or demographic parity, and how to build a platform that essentially turns the health system on its head. And so to approach it, we had to kind of think differently in terms of we all wait till acute care happens and we sort of go into that modality of how do you intervene in that incident. So to build this, we had to kind of step back and say, well, what causes all this? And 80% of our health is driven by social determinants, and it's not predictive. So the idea of building a predictive health AI-driven platform was an unknown 5 years ago. And although attempts were being made, it was mostly an academic modeling, so to speak. And so we approached it from a perspective as we learned more and more as to how to build a whole stack, which was driven by millions of data points. So we aggregated over 150 million patients, CMS data, EMR data, EHR data, social determinants across all US counties, over 3,000 US counties in US, and then connected those dots with even further going down to local epidemiology across 6,000 hospitals in the nation as COVID hit us last year. So the idea that emerged from some of this is that, our data is always going to be biased in some way because those are our sources and that's where we begin. And in some places it's good because you do need to understand, for example, in rare diseases or in certain diseases that affect a certain demographic of our population. We learned, we paid a heavy price in learning last year that Hispanics and Latino population and African-American population with 80% of the deaths were in hypertension and diabetes correlated with COVID. So the opportunity to sort of say, structural racism exists in all of our data. It's endemic in all of our industries. It's a parallel process. Each industry sort of looks at another and sort of builds this into the data sets. So to source from there, you're beginning with imperfection anyway. And so how do you approach the problem of equitable health for all and building a capability which gives an opportunity to attain the highest level of health? So moving away from acute to preventative. And so in order to do that, we first approached as to say, we want to build a precision medicine platform for prevention. And so if I can predict, I can preempt and prevent. And so that's where we began. And that involved, prototyping for understanding social determinants and actually thinking about non-clinical interventions and almost demoting the clinical intervention to the last stage. So begin with communities where we can get real-time sensing of what the needs are, right? Understand what the community needs are, customize solutions for communities, and then move to an aspect of individualized predictive health. And then onwards down to, whether a medical intervention is required. So in order to build this model, you need to source data both retrospectively and prospectively. Retrospectively, as I mentioned, is biased to begin with, but could we correct that over time? And that's where prospective comes in. So psycholinguistic features, aspects that, there are several novel biomarkers that we could discover. We call everything a biomarker. A person living in a community who does not have transportation for health access has several different, biomarkers that might point us in a different direction than what's known in medical literature. So almost by building that community health worker extension approach, we had to take on these different data sets that first allow us to begin to recognize the problem, then understand what we could potentially do to intervene, and then hopefully structure those policies and
I think that's a great point to then transition over. John, I know that Novartis has put a lot of thought into the environmental factors in the ethical use of AI. Do you want to talk a little bit about what you've done to sort of layer on to Sanjeev's points about the social determinants?
Yeah, so as Sanjeev just said, just to add on that, naturally, the data that we have today has been in one way or the other bias in one form or the other. And this is because of historical reasons why how this data was collected and how this data was used. So at Novartis, as you know, we have a position on how we want to do ethical AI. And that simply means we want to do it to ensure that the human rights are really protected, and we want to do that in the design. We want to ensure that the privacy of these individuals are as well covered, and the transparency and explainability components are all there. But you see, if you want to do this by ensuring that the elements like the human right, and we are using AI to empower humanity, we have to cover the whole demographic because we are a global company. And that is why we are very sensitive to ensure that the data that we have are really geographically representative. And we are going to use all means of technology, including externally available technology, to ensure that the data that we are going to use going forward, whenever we we are embedding AI in our processes are biased. So this is a journey that we are consciously committing to, and we want to work with all our partners to help us get into that direction.
That's great. And then Judy, to round out the panel, I know that some of the data sets that you work with based out of Atlanta are a little bit more comprehensive than some other data sets. I'm wondering if you want to touch on what you have done and what you have seen in your research with regard to the fairness in the algorithms and building on the environmental social determinants.
Thanks, Kathleen, for the question. So I'm going to actually wear two hats. One is as a provider who uses an electronic medical record system. Everyone now is very, 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 very interested. I mean, I'm pretty sure Sanjeev is probably surprised, but everyone is super interested in slapping social determinants of health onto something. And so now recently I just noted on my EMR, now I'm getting a lot, and there's a social determinant, of SDI index. And, I think sometimes what we approach with these problems is from a technological point of view. It's like, hey, but I provided you with this information, right? Because if I'm coming in for a consult and now I know like, oh yeah, this patient lives, the thing that's provided there is not even like homelessness, where I may be thinking, okay, how am I going to do a procedure on this patient and then take care of them afterwards? It's done from a technology point of view by looking at, okay, the NIH or someone has said these are the most important social determinants for health. I'm going to slap them here. I'm going to not spend time to figure out, has things changed? Is this patient incarcerated? Are they not incarcerated? The things that matter and the things that can help me make my decision making are not there. But, you want to say, you want a kudos to say that you've been there. And so I see that as one view, but then there's a second view where we notice that specifically for our work, and as we start to take advantage of the big deep learning models, is that these models are able to identify patterns that we human beings cannot identify, or like John said, we need better explanatory tools to even unpack what they mean, and it's almost like a tension to try and figure out when do we push to at least get these insights that are not able, very obvious to us as human beings and researchers, versus when do we stop and say, is this good for everyone? And so we've noticed that a lot in medical imaging, where we can even use chest x-rays to even develop a social deprivation index. We've used chest x-rays randomly to tell you what your self-reported race is with very, very good accuracy. And so I think that it's an opportunity as people embed more data, but there's this historical perspective that everyone keeps repeating that is super important to understand, sort of like, what's the story behind the data and how is it collected? And that's going to be a big, big gap as we incorporate, social determinants of health.
So Judy, I'd love to follow on wearing your provider hats. As a provider, what would be the most helpful as opposed to the social determinants indicator in the EMR? What would you like to see to better treat the patient that's in front of you?
I think it's very patient specific. So I'm an interventional radiologist. What I do is do procedures on patients. And when they're coming from home, it would be great knowing that I'm putting a patient in a chest pod who is not going to be able to, who's homeless, doesn't have a place to get chemotherapy. So this part is most likely going to get infected at some point, and I could change sort of like the access that I'm getting. Sometimes also as when it comes to, for example, and I'm not this type of doctor, but when you're thinking about patients who maybe live in food deserts, right? Or who are overweight, and you want to say, okay, where's my nearest grocery store? Can you get this type of food? As you're trying to tell a patient, maybe you should try and not use a lot of salt. But the truth is, Kathleen, which is why we have to think about where providers provide care. That type of care would be provided by primary care doctors, right? Who are looking at you in totality. But the truth is they only get 15 minutes. My primary doctor only talks to me in 15 minutes as they type the note, else they're gonna go home and enter this note. Now you want them to try and learn where I live and how many cows I have and how many goats I have. They're never gonna do it. And so you can do all these things, but if you're not thinking about how healthcare is provided and who needs this help, and can we sort of optimize and engage the patient in more utilization or saying things that matter, then it's just another thing for us to say, hey, we're doing better on disparities, but it doesn't really move the mark. That's a very pessimistic view, but that it's a personal opinion.
You know,
so.
I think that's a really important perspective for those of us who are not physicians, but have spent a lot of time in the health tech space. You know, we like to think, okay, well, we'll add the ability to collect the data into the EMR or another way where your providers aren't going to be burdened by multiple clicks. And, I think that's a really helpful perspective. I do think to some extent the pandemic has really pushed the needle into the adoption of different types of technology that we never thought would be embraced by the provider community. But I think it is important for all of us as we think about how can we collect better data? How can we, that it has to be in a meaningful, useful way so that providers like Judy can actually use it and improve the actual outcomes, which is, I think, that the end of the day, the real goal. Okay, so we touched on a little bit about precision medicine and kind of bringing the data in. I mean, I think it's firmly established that the historical data is problematic. And I know in our prep call, we talked a bit about the digital divide of folks who are, seeking healthcare, have the ability to see their doctors on a regular basis or getting preventative care. And those who are not, who maybe are coming in, with very advanced disease progression. And I'm wondering, as we go further down the road of precision medicine, how do we bridge that digital divide? How do we pull people in to, whether it's a distrust of the system or if it's an access issue? How do we bring them in sooner so that then that data helps us, for future generations and future learnings for the precision medicine. And John, maybe I'll start with you on this question.
Yes, very good question. So I think digital divide is a reality. COVID, the last 1.5 years have just demonstrated that there are people who have a lot of technological access for their education and some not. Okay, and when you look at in the healthcare space, we are seeing that as well as a campaign, particularly considering that we do a lot of clinical trials. But fortunately, what we are seeing, technology can bridge that gap in many ways. Not perfectly, of course, but in many ways. For instance, we are seeing where you can use smart gadgets. You are seeing where you can use endpoints in very remote places of the world for the patients or the subjects not necessarily to go a long journey or a long way to go to an healthcare center. So if you are aiming at least to collect data or to do some trials, there's possibility of using these technologies in those remote places, and that in itself will be narrowing the equity gap in access to medicine as well as in access to research, and also to expand the scope of the data sets that we just talked about around biases. So we also see that helping and building infrastructure through other organizations like non-governmental organizations, partnering with them is very, very important, because as an organization like ours, we cannot do everything ourselves. But if you partner with organizations who have same or similar values that you cherish as an organization, you can reach so and far wide populations globally. So I think partnership between non-governmental organizations, corporates, as well as governments themselves who are willing to partner with you will really help narrow the digital divide. Not completely solve the problem, but it's the right, being on the right journey to at least resolve the challenges that we are facing.
Right. Thank you. I think that that's a really good point. The partnership. Sanjeev, do you have you seen in your work that moving forward, especially in the past 18 months with the pandemic, that move towards bridging the divide and being able to you know, make sure that folks who have been disproportionately impacted by COVID, do you see that in your work?
Yeah. So I think when I touched upon flipping the healthcare model, right, and what John just referred to was also, you know, you don't have to travel long distances for health. I think it's flipping to, can I send care to you, and rather than you to care. And I said, if we look at, you know, the sort of the taking off of virtual care, where you can begin those interfaces. I mean, we have deployed technologies, and this is obviously not addressing the vulnerable or homeless populations, because everybody you have to begin somewhere. And if you stratify populations in your community, you have all levels of access that would be required to bridge the digital divide. So for those where we can get biosensing at home in order to build those insights into your journey, your health trajectory, do that. If we are deploying virtual reality as kiosks in remote locations, so sending care to you, right? So where you don't have community workers, enough community workers, you don't have enough providers are already heavily burdened. So you talked about 15 minutes, right? Judy talked about having the 15-minute scenario. So how do I deploy enough care out there so I don't need enough human hands to basically at least begin to triage my population, understand what determinants might be required? So we have built in VR our community health worker extension models, which actually go out. So this could be health anywhere, anytime. At your time, you're available at 2 a.m. That's when you're ready to get in front of that kiosk. You don't have to go anywhere. It's in your home, and you could work there in the privacy of your home. If you don't have access to that, and you want yours being physically abused or socially abused in a home setting, you want a community setting, churches, libraries, pharmacies, right? We are deploying this in multiple ways. You think of a place, we can put it in temples, mosques, right? Places of worship. So you can kind of think of this as a model which now helps the community health workers even, right? So we prepared about 25 different questionnaires, which now bridge out, right? So you could be talking about food insecurity, or you'd be talking about, I need transportation to help. So before great companies like Novartis can help, right? They have to also tier and understand what is required to help, right? Do I need a transportation budget allocation for that remote community in South Africa, right? Or I need in Louisiana, I need to get people food because of food insecurity, right? I have to help with that first. So I think the approaches are available now, and the endpoints that John is talking about, we can build those clinical endpoints as well. So I think three perspectives, right? So it's health anywhere, anytime. It's predictive in nature rather than acute. So we don't have to have such a huge contingent of nursing resources or physician resources, because we're always in an emergency mode. So structure that so we could tier our population interventions. And third is approach it from a perspective, can I just send the care to you, right? And triage it effectively from there. So those would be 2 or 3 examples.
On that, let's swap to Judy with her provider hat. With and then we'll get to your research hat as well. With the care to you, as Sanjeev talks about, and there has been a lot of focus in bringing the care to the individual, the patient, not in a clinical setting. Is that from a provider perspective, is that helpful? Are you able to observe certain things about, the patient that maybe you wouldn't be able to capture in that 15 minutes in an exam room? Or is this adding a burden to the providers to figure out the technology to go and find meet the patients where they are. So two-part question.
Yeah. Yeah, so I mean, I totally agree with Sanjeev about the health anywhere, but for sure, healthcare in the future is not in the hospitals. If this pandemic has shown us anything, is that hospitals run like me, hopefully not the rest of you, where you run from every month to month because that's how you survive. And it turns out they cannot be out of pay for a bit. Even 1 month is a big stress for the hospitals. And so it's clear that healthcare will be provided in the communities. And let's look at one thing that's going to completely change this pandemic is vaccines, right? Who's been giving vaccines? It's not been hospitals. Hospitals give vaccines to their employees. It's been the pharmacies, right? The community, and so we have these shifting roles, whether we acknowledge them or not, that maybe as more point of care testing occurs and more of this predictive analytics occurs, that maybe necessarily you don't need, and I'm not trying to replace myself out of a job, but you don't necessarily need to come and see me in the hospital. And look at other things that are happening in the system. There's a lot of compassion fatigue, right? There's a lot of, healthcare provider burnouts, right? And these new models could actually provide a bridge for people to still enjoy taking care of patients, but also, still meet the patient where they are. And so if I were to look at some of the observations, I said, one is that healthcare will not completely be provided in the hospitals as we've known it, and we'll see more of new models, I believe, that will come up. And then the role of the community cannot be underestimated, especially if we look at vaccine dissemination and now with the rapid testing that we're seeing, because those are not being done in hospitals. And then we also see this super specialization of hospitals that has worked for us to get very good outcomes. For example, if you have a hernia and you go to a hernia hospital, you're probably going to do very well because that's all the team there cares about. But when you think about safety net hospitals, in the city, those hospitals have to take care of the things they take care of, which is usually trauma, and they do it very well, but they also have to make sure that when you come for your trauma, you're vaccinated. And so it's this, you're focused, but you're still broad enough to be able to adapt to take care of patients. And then there's something else that we always, and especially now we're in a disease that we're just learning, especially with the long COVID, right? And so this idea of wellness, like who is Judy when they're not in the hospital? And that's where honestly, I think is going to be exciting and it's going to be very disruptive to healthcare. Now, as physicians, I don't think that we are equipped enough that when you come in and you show me, unless you show me an atrial fibrillation and you show me all this data that you've been tracking on your iPhone, that I know what to do with it, completely. But this sense of what wellness looks like, so that when I come here, I can provide care to you, understanding what are your principles, So if John likes to run 2 times a day, then when I see him with a broken foot, then I probably think that John probably wants to be able to run again, but he may come into the hospital as an unknown Black male, which is the most dangerous thing that can happen. And the care that he just receives by being labeled as such is very different. And so there needs to be a transition of understanding what wellness looks like. And we see a lot of people investing and having smart homes and smart devices. And then we need to also transition, like when you interact with the healthcare system, what does that look like? But we know that those may not be traditionally the brick and mortar systems as we've known them.
That's great. I think that what I'm hearing is now we need to figure out, for those of us who are not physicians, how we can take the wellness picture and put it into a package or a comprehensive data set that's going to help you and somehow be able to translate those wellness data points into the more holistic picture of the person and their health, the way they present health. Sanjeev or John, do you want to comment on that? Because I think that's a really important point.
Yes, I think Judy said it all, honestly, very well. and she's in it, so she knows it more than anyone else, what's really happening in the hospitals. What we are seeing, though, from our side as well, with COVID, we've seen a lot and more use of components like telemedicine. Honestly, I can say that there are some areas that we would not have been able to operate without digital technologies during this pandemic, particularly ensuring that the patient journeys are maintained, to know exactly how they're behaving on whenever they are on any of our medications, and also to allow some of our physicians to be able to address their needs during this time when there was no face-to-face interactions. I think at the beginning, there was a lot of challenge, like for everyone else, but meanwhile, you can see that there's a lot of appreciation for these technologies, and some are going definitely to stay. But one thing we also see is that there is need still of expanding the infrastructure to support that, because some of the infrastructures were not just ready yet for that. And that is exactly where the equity element comes in. There are some communities which were completely dismantled and were not even having those infrastructures. So going forward, how do we, as partnership, whether corporate, non-governmental, governmental organizations, ensure that we do not grow that divide, but also help build that infrastructure going forward, to ensure again that the first question you raised about biasness and inclusiveness is still not widened. So I think it is really the ethical elements and the ethical behaviors that we demonstrate out of this situation, the pandemic, using the technologies like AI to be able to have a more equitable communities and build, also meet the patients where they were, just the way Sanjeev said.
I think that's a really good point. Sanjeev, do you want to add in there as well? I know that's right.
I think the move towards home health and health outside of the clinic, we only spend 10% of our lives in a clinic, but we tend to measure it as that's my 90%. And I think that shifting that normality is going to take some time, but we have to, that departure has already begun, right? Because that COVID was a trigger in order to do that. I think the incentives that, at least in the US-based system, it's, getting paid for building that infrastructure that John talks about, right? So I don't think we can address that immediately, but I think the journey towards addressing that and recognition that that's what we have been missing, or that's a big gap, is already a step forward. And I think moving towards a model like this will require us to be comfortable. I think there's a lot of issues around, we also throw up a lot of barriers. We need consents, and we need ability to not share our data, and I don't want this or that. But I think some of that has to do with trust, and how do we build that trust in that digital divide. And so if you can trust me to take your data and do something good with it, with your community, so maybe your insights can combine with millions of other insights, can help us shape what the community trajectory might be. I can lower the number of diabetics in Perry, Louisiana, which is the highest diabetic population, or I can begin a different trajectory just by offering this kind of insight. I think the good sometimes will outweigh the bad. And I think we tend to focus on the bad a lot because, somebody's data hacking is there, all these other issues are there. But despite, I think the good that'll come out of it, and we need to move this mountain to where, the health is anywhere. And I think that we have to keep some of these approaches in mind and actually challenge them. Why? GDPR is there for good reasons, the right to forget. But if I forget, half the population in the community, that doesn't allow me to now change what the trajectory for health equity, because you're now creating health inequity by offering that as well. So I think it comes down to a lot of personal choice, but it's also about education and saying, what do we do with your data, and how we are using your data in ethical ways to be able to shape that. And I think that is another big miss, and the education itself about what predictive health will bring to you.
We have talked a lot about, you know, in this industry, we talk a lot about transparency and, you know, building trust. You know, I wonder, you know, if we could talk a little bit about perspectives. You know, John, I know that Novartis is very focused on transparency, and you know, really being able to bring people along. We've seen, certainly in the United States, a distrust of the system of healthcare, of, you know, we're entrenching positions where we don't need to go into the politics of it, but just looking at the vaccine refusal. And, you know, I'm wondering if you guys have thoughts on how we can, you know, really build up that trust, if there are certain things that you think would be helpful to bring people along so that we're not creating new or different digital divides. You know, John, do you want to start with that one?
Yeah, that's a very good question, and actually it's a dilemma in itself. It's always a question of history as well. So what has happened in the past, and also it's a question of what's going on currently. Data is the new gold. Let's be factual about that and agree all on that. There's a reason why someone may want more and more and more data. And of course, as Sanjeev said it, there are individuals who want it for the good, to empower humanity and to benefit the society. But there are also in cases where, unfortunately, individuals want it for themselves and not necessarily for the humanity. Now, as an organization, Novartis, we've decided to mention transparency and explainability on ethical AI as one of those principles that we want to adhere to. And one of the pillars of our organization is to build trust with the society. We can only build trust with our societies if we are transparent and if they know how we are using their data. And therefore, we are making with the best efforts possible to at least reach out to our patients community, to at least reach out to our stakeholders so that they really understand how we are using their data. And if they bestow any data to us, that we will use it in the way that we've at least agreed to use it. If it includes to benefit themselves and benefit the society, I think that transparency has to be there, and it will lead to a sustainable relationship, which does not have a lot of mistrust. So we have that principle actually to build a very good relationship of trust with our stakeholders and patients.
Judy, do you want to comment on that from your perspective and what you see?
Yeah, so I think we see many levels of digital divide. One is just where you live, right? So we know that it's not unusual for some students, and we know that actually minority communities are really behind in terms of homeschooling, right? Why? Because of internet, right? Something that appears very simple, but I saw this with some of my patients who, when you get rid of the brick and mortar clinic and you want them to come on Zoom, it's really, really a big burden for them. And so, and some, it lowers the barrier. But, you know, what John is saying, and I don't know what would be sort of like the incentive to be able to do such a thing. Like, why do we need 10 networks, you know, when you can build sort of like leverage and sort of at least remove some of the competitiveness and democratize some of the access that allows multiple people and multiple services to be provided. And so I worry specifically, I'm in an academic institution, and for us, we're able to do a research, and because, you know, if you tend to be a little bit in the Midwest or the South, it's one of hospitals that provides care to almost all the patients, right? You're not competing as much like if you're in New York or San Francisco. And so what we noticed though, is that I don't have enough money to buy data sets, but hypothetically, other companies have a lot of money and they're buying this data and curating them and merging them and then deciding, you know what, I'm not going to build my clinic here because there's no one who has good insurance coverage. And they're starting to buy your cell phone data. They're starting to buy all this other data to understand who Judy is. And so this type of power is actually now being centered on specific groups of people who do not always have to follow the privacy laws or, these restrictions of data, cross data set linkage or the barriers that are there. And I think that we really do have to walk the talk to improve access. And sometimes it's also where you can do this type of research that explores ethics. Remember, that if we were to look at one of the biggest papers that has been published in this space is the work by Ziad Obermeyer, who looks at barriers when it comes to specifically looking at a managed care algorithm that was referring Blacks and Hispanics at a later, more sicker patients. That's when they get referred. And so there's real society effect. And the win for me, when I looked at their work, was that the company that built this algorithm was willing to listen. But remember that you have a black box in the technology you're using, but another black box, because for me to reverse engineer what John says his algorithm is doing, I probably will never have access to that type of data or even that type of resources to be able to do that research. And so we have to be really, really conscious, and everyone is data hungry and buying and amalgamating as much as they can.
That's it's true, that I feel like people are trying to do a land grab on the data. I spend, as a technology transactions attorney, I spend a lot of my time negotiating data and who can do what with the data and who owns the data and who can leverage the use of the data and can you take the learnings and who can do what. And I mean, daily, and some of it is just talking about de-identified or anonymized data and what we can do with that. My bias is to free the data and make the data available. I had high hopes for the interoperability regulations that came out, just as COVID was really exploding. And I feel that to some extent there was a missed opportunity, because we were so focused on the pandemic that we didn't have the conversation around the implementation of those regulations in the United States. But we're moving forward. I know that Mickey Tripathi, who's the head of ONC, is still committed to moving that forward. But I'm wondering if we want to pivot a little bit to the use of regulations and regulations in AI. I mean, it has been pretty clear that a lot of our, we don't want overhanded, heavy-handed regulation, but I am wondering if there is some way for a larger policy perspective to shape this. John, I know that you guys have been pretty involved in the EU regulations that were the proposed draft that came out this spring, which deems healthcare as or medtech as a high risk. Do you want to talk a little bit about that and to see if we think that there's some ability for governments to shape and help bridge that divide and trust issue?
Well, what I can say about that is it's not yet a regulation. It's a draft, we are getting the opportunities to respond to that. I have to say there's a lot of willingness from both sides to work together, to lean in and listen. And the regulation is for good intentions, really, because we've also seen cases where AI has not been very good for humanity in terms of empowering humanity or in terms of areas of biases and all these kind of things we know. There's a lot of negative coverage on that. However, from our side, our position is that we want to use AI to empower humanity. And we want to ensure that together, actually, with what we are seeing the regulators are saying, including the EU, they see also AI as an opportunity really in the healthcare industry to use it for the benefits of humanity. So the principles that we've seen them defining, the area they've seen them defining, comparing to the principles that we've defined, there's a lot of matching in those principles. And whenever there will be, of course, any form of differences, whether it's on areas of medical device, actually, it's not that there are differences. With the new regulation, that there are differences with what we think of what the medical device. It is just that this regulation, some of them already exists in other provisions or other laws from the EU, and therefore we are trying to find how can we align that. So that's the discussion going on.
Right. And Sanjeev or Judy, I don't know if you have thoughts or perspectives. We haven't really started to go down that path in the U.S. at this point in time, but Sanjeev, do you want to add some thoughts?
I think U.S. is still in a learning phase of what we're all learning in terms of what trust means and what transparency means. And I think before we approach, almost trust would be an outcome, not, you could talk about we build trust, but you have to almost demonstrate it in some of the things you do. And I think so, being clear about your purpose, right? So purpose as an AI-driven company, I think elevates you to beginning to have people know why you are doing this work. How does this work impact your personal health trajectory, community health trajectory? And I think, to Judy's point about, people don't even have access. So I think simple things like very, very low cost solutions, just like text messaging, right? And then, hey, are you feeling well today? Or just reply one or two, don't have to be too literary and then illiteracy. And there's a lot of barriers in our communities. And so I think technology can help, and you have to begin where they want to begin, right? So the purpose of collection of all of this data is to develop a better AI model. And I agree with John that nefarious things can happen, and that's what the regulations are about. But I think it's repeatable capability to engage with community, whether that's a health system, a hospital system, a payer, a provider, and building to purpose, right? So build to purpose, demonstrate that purpose, bring about a collective intent and collective impact in a community. And I think we can begin to see where regulations might be required. I think putting guardrails on too early. What does harm mean? Harm, if I have a train, the moniker we use in AI, right? If you have a train going down the path and there is two roads and one has 5 people in front of the train and one has 1 person, who would you harm, right? Which direction do you take? And I think so those are all constraint optimization problems. You have to decide what the path of lowest harm is, whether that's to the patient or to the community. And not all choices will be binary outcomes. It's not a 1 or 0 with AI. It's always going to be some level of probability. So I think recognizing how we create and look at that outcome in that patient, I think moving a percentage, 10% improvement in a community would be massive, right? So I think that's where we drive some of the insights for how regulations should be structured. I think it might be good to just put some structure to it now, but we are still in the learning phase of how data will help shape and change.
Yeah. So I'm hearing, don't put too many guardrails right now because we're still learning. Judy, do you want to comment on this as well?
Yeah, I think, so the problem is that we're seeing, at least for medical imaging, a maturity, sort of the maturity model now is that, the hype is kind of dying down. People are admitting, okay, maybe it's really hard to do this, AI thing in healthcare. And so as we start to see models being built, being tested, we see a lot of failures, right? And, that can affect a lot of trust from the people who are the end users. And it's because, it's something that you don't understand, and then now it's not working as well, or it's making silly mistakes. But some of the the cautionary things that I've noticed is that people say, well, like for example, our work on models detecting race, people said, well, then if you can identify such sensitive information, then we should not be sharing data. We should keep it so that no one else can ever be able to do this type of work or go back and and that's the wrong approach, because you completely kill any innovation or any attempt of using team science to help you be able to identify what the model is looking at and how to mitigate the biases that can arise. I think everyone on this panel admits that the biases are there. We just have to acknowledge them and then try and mitigate them. And as we deploy these AI systems, and so the regulatory, I think sometimes it's just difficult to undo or update a regulation. And so I would more encourage for us to think about governance, where we decide what are our principles and what are some of the winning strategies that can be our guiding principles. Remember, these technologies will also leapfrog in developing countries, and those countries will not have capacity to build regulations. And so if we don't think about governance, then we miss an opportunity to try and make AI that works for everyone. Because what's going to happen is that we'll now have advocates and lobbyists who are trying to, instead of trying to really invest on figuring out what works for us.
Gotcha. I see where the panel is, and I think would it be fair to say that we need to figure out where we're going, perhaps with Novartis's modeled on their principles and their statements, and if we can come together with a internal governance at the industry level, then we should stick with that prior to moving to a more formalized set of regulations for something that's not quite fully understood yet, because it's still early in the process. Well, guys, I see that we are a little beyond time, so I really want to thank all of you for participating in this great discussion, and I could certainly go on for hours. I'm sure we all could, and to thank our audience and the conference for allowing this conversation to go through. But with that, does anyone will do quick final words? And Judy, I'll start with you this time.
I mean, it's I just don't want people to leave the webinar feeling like it's all doom and gloom. I think it's a fantastic time. We see a lot of opportunities for AI. Some of my work really with others is looking at how you can use AI generated metrics to actually narrow the disparities. And so it's an amazing time and exciting time to be working in this field. And I really, I just always say that you just have to come with a humility that you don't know everything. And once you do that, then you're always learning and you're always trying to push the boundaries. And that way we can always be sure that our true north, which is to provide the best care to our patients at all times, is really achieved. And so I'm excited to be working in this, and I couldn't have this is like the best time to have been born to be working on this right now.
That's great. John, next to you.
Yes, thank you very much to the audience. I agree definitely here with Judy. We see AI as a huge opportunity actually for the unmet needs in the healthcare space. And we are going to ensure that we are doing in a responsible and ethical way to ensure that whatever data we have, whatever information we have, we are using it in the right way just to empower humanity. And therefore, I agree that there's a really, really a bright future if these technologies are used in the right way possible to protect mankind.
All right, and Sanjeev, last to you.
I think a moonshot purpose is apt here. I think thinking we're not going to get through this in a year or 10 years. It's a multi-year journey. AI is multidisciplinary. Human health is many outcomes at the same time. We have evolved. I mean, when John talks about global humanity, and we have evolved from a point of single intervention, right? Understanding single disease and single intervention. And I think AI gives us a huge lift in terms of understanding why can't I deploy multiple interventions or understand multiple health trajectories at the same time. No physician has been taught like that. Our medical literature is very limited in that. So I think the focus on open data, open science, and ability to contribute and work with the community. When we started this, we went to the most complex patients, the very complex ICUs in the world. We worked with the academic medical center that gave us very deep insights into ICU physicians who think in real time. as to what's going to require to be intervened. And they have not one algorithm, they are processing 50 algorithms at the same time. So I think that's what AI brings to you. It brings that ability to process 50 algorithms or 500 algorithms and being able to pinprick where that is going. And I think we have to acknowledge that strength and purpose and ability to shift this mountain of data and health we work with. And then, and the purpose will sort of take care of the guardrails. And I think if you're transparent about that, trust will build. So,
well, great, guys. I think on a very, very uplifting note towards the end. So thank you to our audience. Thank you to the conference, and thank you to the panelists for a great discussion. I hope everyone has a great day.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.